Okay, hello and welcome to our 6th Planetary Health Academy and the second one on clinical medicine and planetary health. And we're really happy to have 3 more clinical perspectives today on the topic of climate change, biodiversity loss, and the impact on human health. We have Clemens Becker today, Andreas Heinz, and Nightingale Wakigera, with 2 different inputs. So one from geriatrics, pediatrics, and psychiatry. And we will start with Clemens Becker, and I'm really happy that everything worked out fine now with the first technical issues we had. So you're professor at the unit Digital Geriatric Medicine at the University of Stuttgart, and you're also head of department for the geriatric medicine in Stuttgart at the Robert Bosch Hospital. And in your research, you're focusing on early risk prevention for elderly people, and obviously also to this topic belongs heat waves, as we had in the last week, and how we can prevent heat stress in elderly people and how we can increase their resilience. So I'm really pleased to have you here. You may start if you want.
Thank you. I think that looks okay. Hello, everyone. It's good to join you. So what I will do today is that I will give you some insight into our work that has been ongoing for a little more than 10 years now. So the approach that I will choose is that, well, I will frame it in the context, let's say, of the Lancet Countdown. Of course, mentioning that what I'm covering today is one aspect out of many aspects that everyone is aware. The second point that I would like to address is our experience over the last 10 years, let's say, on the communication and, let's say, the opinion building process that we have encountered in Germany. So let's say to start with, in 2003, when we heard the first, so to speak, bad news on the press and media coverage around climate change and heat waves in particular, now this is more or less like common sense. I was very surprised that the public reaction by, let's say, public health, some of the health ministries in different states in Germany was that we did not have any negative effects in Germany, whereas we knew that from France, thousands of people did die in the June, but also a lot of people during the August heat wave, which is now 7 years back. So we thought this is totally unrealistic because from our clinical perspective, as a large hospital here in the southwest of Germany, we did see a very different picture. So what we then did, that we started to work with health insurance data of the largest German health insurance fund, and started with the Southwest, and could actually demonstrate that close to 1,000 people died only, so to speak, in nursing homes, care homes. And of course, nobody would expect that this is double the effect in the general population. If you take into account that for every person who's in a nursing home, there's at least 2 people where you have a family care situation. So we published this data a little more than 10 years ago. And we then decided internally that apparently because of the public neglect, we would like to pursue and follow these developments, not only on the epidemiological side, but also, let's say, thinking about preventive efforts and so forth. So one thing I learned is that very often, if you have a starting problem, there's really public neglect, and it takes a lot of work and effort, and you have to identify the right stakeholders to work in this topic. And it lasted actually until this year, until we have some more, let's say, involvement, for instance, from the Federal Ministry of Health, which actually released a website just 2 weeks ago on this topic, let's say, to reach out to older families and their family members. So the next question, what we asked then, is not only looking at the data in Germany, but we also looked at the neighboring countries. Let's say, starting with Europe, of course, we have different situations across the world, as we all know. And for instance, if you take Switzerland as an example, where the public health experts from the Basel University started to study that, they identified that in a somewhat similar heat wave situation in 2015, the results in terms of the mortality in Switzerland, despite a number of public efforts, was virtually zero. So it appeared that at least, let's say, if you consider the total numbers, there was no, let's say, further development. And the interpretation of that was that even though you have, let's say, public healthcare planning, you have heat action plans, you have a number of other things, that at the actual, let's say, place where you would have to deliver the care, so for instance, in the people's home or in care homes, the action stopped. So let's say if you discuss these with physicians and if you discuss that with home care agencies, you found that all in these instances, people hoped that someone else would do the work. So the physicians would then tell the nursing home people should do it, or the, let's say in Switzerland, this would be the SPIDEX, the community nurses should do it. And if you would talk to the people in the nursing homes, they would say the physicians have to do it. So at the end, to make it a little bit simple, really nothing happened. In France, the situation, to my understanding, is somewhat different. There were some very relevant positive developments, but if you discuss to experts from Paris and other places, it seems that for the last 4 or 5 years, actually, these initiatives have been slowed down. But maybe we can discuss it later on. If we, let's say, if we look at public health data, and I think this is quite relevant if you're interested in climate change and to look at the effects, we should be cautious because some of these data are somewhat difficult to interpret. And if you look at it from a general population level, it's very relevant that often if you have to do this in real time for epidemiological purposes, it's totally unrealistic. So what we've seen to clean these data and really understand the data, very often it takes 1 year or more for public health reporting. And this is really, I would say, a major point. You really have to work with experts in the field who understand the pitfalls of very, very large databases. Okay, just to move on. If we look at, these are German data, I'll come back to that, and looking, let's say, what are the critical points? We can see that beyond 30 degrees of centigrade, either if we look at the situation at home, that's to house or care home situations, that we call this the first stage of heat waves is around 30 degrees where mortality really goes up. And then let's say if temperatures go beyond 35 degrees and more, we really have a terrible situation. However, if we discuss this on the global level, and of course planetary health is more than just one country, we have to consider a number of other things. I'll come back to that. So we wanted to take a very simple approach, and that for people outside of Germany is not so easy to understand. But in Germany, if we look at the very old and frail population, we have different levels of care, which are defined according to the, let's say, legislation. And this, as an example, would be a very simple measure. So we can see that people who have higher care levels really have an excess mortality. And for the people, let's say, that are dependent, let's say, on other people or their families for more than 1.5 or 2 hours, it's really a very, very dangerous situation that we have to take care of. My understanding as a clinician is that with most of the heat waves, we have about 1 week where we can respond. So a heat wave doesn't come overnight, and we have some time window to respond. And again, I'll come back to that. Now let's look a little bit at the situation of other countries. What you can nicely see here that apparently if you go to different geographical regions like Athens or Madrid in this case, or if you go to the north of Europe like Helsinki or Oslo or Stockholm, the situation is somewhat different. So you have to consider if you plan, let's say, heat action planning and so forth, that you have to adjust that to your given situation, because people have cultural, they have social, and they have physiological ways to adapt to that. So there's not one answer for every country, major point. So this is an example going, let's say, beyond Europe. And you can see that if you would take these lessons to Beijing, or if you take them to North America or Australia, you have to consider that. And I think that's also one of the things that we have to learn, that of course we can consider the different countries at different laboratories learning from each other, but it's not that one size fits all. So what do we expect for Germany? What do we expect for Europe? The prognosis, I think the models are relatively strong, and we do expect that heat waves will be much more common compared to the situation that we currently have. We expect that the heat waves will have a somewhat longer or maybe long duration, which is relevant. I'll come back to that. And of course, we expect that some of the somewhat moderate heat waves will change to heat waves beyond 35 or 37 degrees, which in some places of the world, as you know, let's say, are already relevant. As a geriatrician, as a specialist in old care, we know that every sudden change to an older person is something difficult to respond. So if we're discussing resilience, let's say the adaptability of people to these reactions, we know that if you're 80 or 85, it's much more difficult to adjust. To make it in this context a little bit clearer, we know that, for instance, heat waves that occur relatively early, such as the early days in June, are much more dangerous than a second or a third heat wave that might come in July or August. So the bottom line is the sooner, the worse. We've seen this over the last 10 years. One aspect, let's say, is the day when this actually occurs, and very often people would not expect it. So that's one story. And the other point then, of course, is the duration. So it's quite different if you have a heat wave that lasts for more than 10 days, like the 2003 heat wave, which actually went longer than 2 weeks. So that in terms of the body adaptation, physiological changes is a different story. So let's have a brief look. Let's say, what are the current activities and the stakeholders? What I learned is that it's very often not the organization itself, but there's certain persons that you have to identify and then start to cooperate. So if you want to change something, and I expect that most of you want to change a certain situation, you have to find out what is your personal network. So for instance, we have identified certain experts. For instance, let's say our Federal Environmental Agency has some persons that are definitely very, very committed to this topic. We have at the, let's say, the development of the HEAP app that was developed by Professor Matsarakis, which originally comes from Greek, but is now responsible for the health meteorological issues here in Germany. Then we had a long latency, as I've said, by our federal CDC, or also the subdivision of the Federal Health Ministry, which is called Bundeszentrale für gesundheitliche Aufklärung. It took them years and years and years, and nothing happened. Now, since 2 weeks, I think they have a proper website that they have developed, and there's a lot of linkage to other, let's say, media activities and activities such as the one that we're attending today. Some universities have picked up the topic, some, of course, with a longer journey and a longer and stronger background. Then we have seen that in some states, the situation is quite different. So, for instance, we had one example of one state in the middle of Germany where a number of the people who haven't even weren't responsible for that developed some very dedicated and specific interventions for care homes, which are now a blueprint, I would say, for the rest of Germany. So identify the experts and do not expect, let's say, anything from big organizations, and then start working with them, and it will take time, very often a number of years or maybe even 10 years or longer. So that's the roadmap that I would like to stress. I'm not going to go into every detail, but it makes sense to develop these sorts of roadmaps and see where are your knowledge gaps or cooperation gaps and try to work them. Sometimes it's useful also to work, let's say, with social media, grow, let's say, attention. One of my personal theories is the surfing theory. You always have to think about when is the best point of time to release some news. And of course, like this week, I had a long interview with a radio station. We had some television coverage. So normally to get some of this news out into the world, May and June are very appropriate. And of course, sometimes you can have the best data to convince other people, but if you send them out like in November, no one will listen. So that's something I think that we have to keep in mind. Now let's go back as a clinician. What have we found out? And of course, one thing is that we have to keep it somewhat simple to make it workable for GPs or, let's say, community nurses and so forth. If you make it too complex, it will not work. So we have to identify, using a sensitivity approach, who is at risk. And if you would consider that some of the general physicians, for instance, are on holiday in the summer, they have to identify maybe the 5 or 10 persons who are at the highest risk. Of course, some of these things are quite simple, but sometimes not everything is thought through. So you can start with age. Normally, let's say as a rule of thumb, I would say 75 plus are the persons who have been mostly affected. People who do not have a spouse or family people looking after them. We know if you go to the 3rd or the 4th floor, this was very evident in France in 2003. If you were living on the south side of a building, your mortality was twice as high compared if you lived on the north side. Low socioeconomic status is always a problem, and people, of course, who have gait problems and maybe who cannot go shopping or maybe to an air-conditioned situation in the city are at risk. Some of the morbidity conditions are quite evident. For instance, coronary heart disease or congestive heart failure, renal disease, but sometimes other things are overlooked. And one of the things that is overlooked very often, I think, are people with lung disease, such as COPD. And as you can imagine, people who have beginning cognitive problems, first forms of dementia, very often do not look after themselves. And in a very heated situation, also the cognitive capacity decreases. And the point of medication will be discussed in a minute. So the point is that we have identified workable lists so that it's relatively easy and everyone has to say, this is my responsible and not the responsibility of someone else. We have to look for cooperation networks in agreement with community nurses. What we found is that there's a lot of volunteering that is doable. The interesting legal situation is that, for instance, in Germany, heat waves are not defined as a catastrophe, whereas, for instance, flooding, earthquakes are. So to identify some of the federal mechanisms, let's say to get, for instance, volunteering on a large base involved, we have to change the legislation. That is something that we haven't succeeded, but we are working on. So the third thing is that I would strongly recommend that every older person should have a medication review, for instance, in April or May. And one thing is to get rid of some of the harmful medication, and the other point was to discuss with the person what should be done if, for instance, in June, a heat wave is coming. And what is interesting, even though a lot of these people are really specialists, but some of these interactions, I'll come back to that, are really unknown. I'll skip that for the sake of time. So what is, let's say, obvious, let's say for medical specialists, and you also learn this in your medical school, is that, for instance, you would reduce the dosing of a diuretic, you would and should reduce the dosing of the, for instance, antihypertensive medication. But as soon as we get to other topics, things are getting muddy and people just don't think about it. One classical example, which is really drastic, is if you take pain medication of opioids that are administered on the skin. If you have a heat wave, let's say the dermal blood flow can increase by 400 to 800%, and the dosing of your opioid can increase by factor 4 to 8, and you can potentially die, let's say, of overdosing by, for instance, fentanyl. The other point, which is often overlooked, is the role of other medications in terms of their anticholinergic power, and that means you cannot sweat anymore. And if you're physically active, and every one of us is, even if you're sitting or standing, it means that we have to get rid of the heat. We are not dogs. So in order to do that, we have to sweat, and that, let's say, is, followed by other changes of blood flow, of renal blood flow, hepatic blood flow, and so forth. And a lot of the medications actually decrease the sweating potential, and that can lead to anything like heat problems up to a heat stroke. That's my final picture. You can find appropriate dose adaptation websites. And one thing that is underused in most countries, including Germany, is the role of consulting pharmacy. So everyone also could go to a pharmacist, even if the physician doesn't have time or is on holiday, and ask if something has to be changed or should be changed. One thing is fluid intake, the control of body weight. All of these things are not witchcraft. And let's say for very critical cases, of course, you can also administer fluids subcutaneously, which is rarely done, but is always an option. Almost my final slide. An easy way to monitor older people is to take the temperature. So if someone during a heat wave has a body temperature, a core temperature of more than 38 degrees, things are getting critical. From, I would say, 39 onwards, it's really something where people should be admitted to the hospital, because the case fatality, if people really have a heat stroke, is very, very high, in the range of 30 to 40%. So this is nothing where we can wait, but we have to respond and admit people to hospital care. So to wrap up, I think in a sense, heat waves are an example, let's say they're an indicator how our society can respond, let's say, to something that we should appropriately manage. Heat waves for me are not coming overnight. So normally we would have the time to respond. We can also monitor as a key performance indicator if physicians are moving in the right way and right direction. So 3 years ago, I had a doctoral student and she interviewed a lot of the patients in this area and physicians. And everyone, she asked if there was a modification of medication in heat waves, but also before heat waves. And the answer is zero, or was zero then. We didn't do this year. So let's say what we learned from that is that at least we can use that as an indicator. The good news is that in October this year, let's say the German centralized meeting, Deutsche Tag, will have climate change as a central topic. And we hope that this process of awareness, action planning, and action is now hopefully entering into a new era. But I think even though the political agenda of most parties with the federal election this year is full of action for climate change, I think if we're not going to push them, they're not going to move. At least that's my conclusion. Thank you.
Thank you very much. I hope you're not right for your last sentence. I need to say, I hope they will do something. So, but I think I totally understand also your perspective and your kind of skepticism about this. But we will do our best. I can promise to push this topic forward, and so that in the end they indeed will do something. And also regarding heat waves, I don't know if you know the book, but I would like to recommend it to our audience, because there's a book from Rick Keller, and he's a historian, and actually he wrote a report about the heat wave 2003 in Paris, and he did interviews and talked with the police and the public health institutes there, and really tried to rebuild the story of how this heat wave could be that bad. And if you want to learn something about how heat waves have an impact on older people or lonely people or people with mental illnesses, I think this book is really the best way to kind of really experience the situation. It goes deep down your skin, I would say. And I would like to hand over to Martin, who's going to present the next speaker.
Thank you very much, Sylvia. And perhaps you can have a link for the book in the chat. Just to Clemens, I'm just coming. The hour before, I was in a meeting with one of the largest German parties, to some members of parliament, and I think it was the first session for them to be exposed to our topic. And they were very carefully listening and were very clear at the end that this is the beginning of an intensified cooperation, because they understood how critical the subject is. I think really the wind is changing now, and it's very, very important, the work you do and all the others you have mentioned, that this now gets attention and be listened to. Even at the beginning, the chair of the meeting was talking about her father, who is 74 and had now a crisis with blood pressure during the heat. So she was very interested in seeing kind of what is the physiological connections and so on and so forth. So I'm very hopeful that things are changing. But we will have to push for it. If we are not pushing for it, you know, it will not change. So it's my pleasure now to introduce Nightingale together with one of your kids on the lab. Nightingale is a registered nurse, a mother. She's co-leading Child Health in Planetary Health. That's an initiative of the Planetary Health Allianz, CHIP, a project that works with and for children to connect child health with planetary health. You're also leader of Africa Community of Planetary Partners for Health and Environment. You have been born and raised in a village in rural Kenya. And from that, you know that the direct and healthy connection with natural environment you got to know as a child are rapidly turning into rare luxury. You're also you're now living at the west coast of the United States, but you have still strong connections with the networks for planetary health in Eastern Africa. And it's a pleasure to have you here today to talk about pediatrics and what you're doing with CHIP.
Thank you. Thank you very much, Martin, for having me today. I will go ahead and share my screen. Clear on that side?
Yeah, looks good.
Okay, thank you. So yes, I'm very glad to be here. And I'll just give you a brief overview. Like Martin said, I'll be mostly talking about children and the connection, their health, and the connection with the health of the planet. And so I will be, you know, on the other side of what Professor Clemens was talking about, but really also looking at the intergenerational connection as well. So I will briefly talk about myself, then I will also talk a little bit about the core layers of my identity and why I so deeply care about this topic. Then we'll touch on goals, and I have the child on my lap and another one. And if by the time we get to that point, they're still ready, they will share something small because they enjoy participating. Then we will have a brief overview of child and planet relationship and the future-oriented work and how to best work together. Then talk a little bit about CHIP, my project, and then future opportunities to collaborate. So thinking about planting seeds and nourishing seeds of hopeful solutions, and then highlighting the vital importance of community. And we can look at community in different ways. You can look at it from a local perspective or even a global community as well. And thinking about how we are all, we can all actively be agents in shaping the future that the children now, the future children are going to inherit. And then talking a little bit about equity, sustainability, and balance. So I would also like to invite you, if you have a child close to you, whether it's physically or even in your heart, in your mind, just bring them closer as we have this conversation about child health and planetary health. And also think about the issues that affect both that child, those children in your life, in your community, and the health of the environment and of the planet. So I will invite my friends here and my partners to share a little bit. So Rahema is here and she will share the vision of CHIP, Child Health is Planetary Health. They are involved in as much as possible in shaping the vision, the mission, and the work of Child Health is Planetary Health. Rahema. would you like to say the vision?
Our vision is healthy children and a healthy planet for all.
Thank you. And then Fatili, that was Rahima. Rahima is 6 years old, and you want to say how old you are and your name?
I am 9 years old. My name is Fatili.
Please share the mission of CHIP.
Our mission is to collaboratively connect care for children with care for the earth.
Thank you. And then they will share briefly, I think, a song by John Denver that is The Flower That Shattered the Stone.
The earth is our mother, just turning around, with the trees in the forest, roots underground. Our Father above us, whose sigh is the wind, paint us a rainbow without any end. As the river runs freely, the mountain does rise. Let me touch with my fingers, see with my eyes. In the hearts of the children, a pure love still grows. Like a bright star in heaven that lights our way home. Like the flower that shattered the stone. Sparrow.
All right, thank you guys. Thank you, Tom. Thank you, Boo Boo. Okay. So yes, The Flower That Shattered the Stone, and you can see that song moving forward. So just talking a little bit about our relationship with the planet and looking at a Lancet Countdown, where it talks about the life of every child born today will be profoundly affected by climate change. And how we respond will determine the world we live in tomorrow and will shape the health of children across the globe at every stage of their lives. So there's even where it, we're now talking of old age, but for the future, it is quite likely that we will, and even presently for some communities, we're talking about children and people dying not from old age, but from effects of climate change. And so it is a very important topic for us to think about as we move forward. And as we just heard from the previous speaker, there's also the heat as a big issue, the toxic stress that comes about with affecting the mental health, the psychological well-being of the children. And we also know that if the family, if the community is affected, it inadvertently affects the well-being of the child. And it's also very much connected with the nutrition of the child as we speak. So like I shared and Martin shared, I was born and raised in rural Kenya, and it was quite rural. I will just diverge a little bit and say that I talked with my dad this morning as I was thinking about this talk, just because I didn't know exactly what type of home I was brought into when I was born. And he told me that I came home to a mud hut. So, and I think that is beautiful. I don't live in such anymore, but I think that it's just thinking about that type of idea, that it's trying to be as sustainable as possible is the goal. Obviously, we're thinking about other things. We're thinking about health and well-being and homes that are going to have us better grounded, since they won't be makeshift homes. But it's also thinking about the connection right now for the child with the environment, and how much our children are gaining from the environment, or losing for that matter, because we're now seeing that there are lots of respiratory issues that are coming up, and they're all related to the natural environment, the toxins that we're releasing into the environment, then the air pollution and the heat that we just talked about. And then thinking about urbanization as many people move from the rural spaces to the urban spaces, and thinking about these again being safe green spaces. And this is where, and we also have to think about, are they equitable spaces? And that's why it's important to think, as much as we think about ourselves and the children that are close to us in one way or another, whether you're a teacher or a health provider or a parent, is thinking about the other child in those spaces, and are they getting access to safe green spaces? Because there are still enough green spaces out there, but are they safe for our children? And then thinking about the health of our children in terms of either malnutrition or obesity. There's a lot of screen time now, and especially looking at this era or this period where we've had COVID-19, and it being that children have had to stay out of school, where there's so much engagement between children and the outdoors in some ways, and having to stay indoors and having to do a lot of screen time. And research tells us that the more screen time, the less engagement. And really, it's not even just research, but common sense. If even for the adults now, we see that the more screen time we have, the less time we have for the outdoors. And what does that do to us for our mental health? So these are, and just to touch a little bit about Africa, and really I'll talk about the Africa that I know. It is that we now are moving away from malnutrition in some areas, as we have middle class people in those regions, and going to obesity, because we're looking at development. It is, how are we looking at development is also the question, and looking at the nutrition aspect too. So we, in this situation, we have to really think about, are we raising a sustainable community? Are we raising children that are resilient? And then we also, so there's an organization that's called Children in Nature, and what they advocate, and so many other organizations, they are advocating for bringing children more outdoors, because once they connect with the outdoors, then they value the outdoors. And once a child values the outdoors, then they will know what they're losing or gaining. And especially now with more and more development, I know we have more talk about sustaining forests and the green spaces. It makes sense, but there's also another drive of development, where for a lot of development to happen, we have to cut down trees, we have to eliminate green spaces. So if this child does not know what they are losing because they haven't been exposed much to it, then they will not advocate for its retention. And so it is very important for us to introduce these discussions from an early age in their development. So also thinking about child health being grounding and unifying for us. This is a conversation that not only needs to be had within the health realm, but also the environmental realm, and connecting both of them as strongly as possible. So having conversations and making sure that we center the child in these discussions, because this child is the one who's going to become the future healthcare provider, the future policymaker. And so again, as much as possible, have the child in the middle of this discussion. So we think about, for example, the Convention on the Rights of the Child, child-friendly communities, and children in all policies. And looking at such documents, you'll be able to see how to better engage children as we continue with this conversation of realizing that the children are actually, they have something to bring to the table from an early age. So is there potential for a greater emphasis on child health within planetary health discourse, advocacy, and action? And the answer from my end is yes, there is, because we think about cultivating deep relationships between and partnering with children, and thinking about really a bottom-up conversations, both from the community level, from the educational levels, academics, and also the health point of view as well. So it's also important to include the indigenous communities or indigenous populations, because so indigenous and also intergenerational connections are so important, because it is from these conversations that we start breeding, well, for lack of a better word, it's not really, we're not breeding, but we're raising children. And it's raising these children that, again, understand and appreciate these topics from an early age. So, and involving everybody at the table, the professionals, nurses, doctors, lawyers, teachers, as well as the community members, as including people who are like the child care providers at an early age, such that we instill these values from really early on. So there's the Hart's ladder that was developed by Roger Hart in 1992. And what it talks about is, it talks about several levels of how we can involve the children. And there's manipulation, there's tokenism, but there's also involving children at an equitable level, where we have these discussions, and that's where we have a fine line. So we always have to be aware of how we're working with the children. We share what we know, we listen to what they have to share, and then we see how we can collaborate with them. And that's why we say it's collaboratively connecting with care for children and care for the earth. So future opportunities for collaboration and building. There's an International Society of Social Pediatrics and Child Health that also has ongoing webinars about child health and climate change. And there's a webinar on planetary pediatrics. There's also a journal on pediatric health care. And they also have a special issue touching on planetary health, environmental justice, and child health, as well as celebration of the Youth Rights Day, which is also World Children's Day, which will be on November 20th. And I'm just sharing these so that we can think about ways more and more on how to collaborate with the child. And we know we have like Fridays for Future, we have children or youth like Greta Thunberg and so many others. I mentioned Greta because she's now well known, but there's so many children, young people who are who have a lot to say. So in our communities, it is finding ways of giving them that space, listening to them, involving them in these discussions, and also thinking, like, for example, with the clinicians, time is always a factor when you're seeing the children, whether it's a wellness check or whether it's a sick check, but it is checking to see not only about what are they eating, but thinking about involving even things like clinic gardens, school gardens, community gardens, and talking about it is during such times that you can discuss foods and where they come from and the effects of the food that we consume to the environment and how it comes back to affecting us in return. So I think that's what I would like to share for now. Looking forward to having further discussions, and I appreciate being here. Deeply appreciate the conversation. So I think I still have a little bit left. So I will just share a little poem that I was playing. We were playing around, the children and the family. I'm looking forward to learning, growing, building, and healing together, united with our children, for all children, and for our one beautiful home on this wonderfully complex and living planet that we all have the honor and privilege of sharing together. So you can reach out to us at childandplanet@gmail.com. Thank you.
Nightingale, thank you so much for being with us and sharing your passion and your vision and making it so alive and so unique. We have been knowing each other almost a year now, and it's getting more connected. Also, we have never met in person. I feel very connected, and it's very great how you share with your children your vision and what you stand for. Thank you so much. So I move over to introducing Andreas Heinz, our third speaker, and we will, I think, also see at the end that somehow these three perspectives are also connecting on a very good level. So Andreas is professor of psychiatry and director of the Department of Psychiatry and Psychotherapy of the Charité University Medicine Berlin. Your research focuses on dopaminergic and serotonergic neurotransmission and their respective effects on reward-dependent learning, positive and negative mood states, and decision-making. A second research focuses on social exclusion, stress, and transcultural psychiatry. So I'm very pleased that you're joining us for this session today. Andreas, over to you.
Thank you very much for the introduction. I'll give you a brief overview about some findings regarding social inequality and mental health and their impact and perspectives also for questions of climate change and planetary health. So let me just briefly start with describing the focus of our topics. So when we talk about mental health, of course, you have a very broad area from well-being reaching into mental disorders. And there is a worldwide gap in how patients or persons with mental illness are treated. I have a personal friend who was working for the UN Committee Against Torture in Psychiatry, and he quit his job after he had to visit one country. They're not allowed to name the countries, but it was a Middle Asian country, and there he found patients to be locked away in wards for many years. He also found the illegitimate daughter, or the daughter not out of marriage, but out of an affair of one of the ministers who had been interned there all her life and was not allowed to leave. And he was so shocked that he had to give up. But also in high developed and rich countries, it's just recently as in the last couple of decades, that there has been a stronger push towards more equality and towards a stronger ability of patients to participate in their own decision making. So one of the cornerstones of moving rights of patients with mental illness is the UN Convention on the Rights of Persons with Disabilities, and mental illness and all other chronic diseases fall under the protection of this convention, and it has a famous Article 14, which says that there should be no specific regulations taking away the liberty of a person because of disabilities. And in Germany, we had a high court who said, okay, that does not mean that somebody with a mental illness can be, has to be kept if he or she is dangerous to others, which sometimes happens. It's a very small percentage, unlike the prejudice, but it does happen. Forever without treatment. The liberty doesn't mean that a person who, let's say, has a brain tumor and within the brain tumor has epileptic seizures and within the seizures still wants to drive a car. You don't have to have that person drive a car. But whatever you do needs to have certain regulated steps on what you can do. And it depends on if the person really, key point, is not able to understand what goes on and not able to consent. You need to try to convince persons of other options. You need to avert detriments of health, for example. You don't have to accept that a person who has from alcohol use dementia, Korsakoff's dementia, and forgets everything. We had such a patient who didn't understand anymore why she needs dialysis because of her kidney disease. So you can still provide dialysis to a patient, but you need to go through all these steps. You can't just say, okay, we know better than you do. And of course, there should be an independent organization, not the medical institution, but a judge, to actually look at the evidence, get independent information from a non-involved medical doctor, and then make a decision. So what we're talking about is a fraction of persons that have, from a medical point of view, a disease, and that have, here comes already the social aspect, even stronger, a sickness, which means you have an impairment in social participation and or you suffer from what you have. So why is not every disease here in red? Because there are disease symptoms, at least from a medical point of view, that patients don't suffer from and do not feel impaired in their social participation. I always quote a patient who had hallucinations, acoustic hallucinations, voices that you heard, but he came to our clinic and he said, please leave my voices alone. My voices counsel me how to invest money at the stock exchange, and so far they've always been correct. So, you know, from a medical point of view, you can say hallucination is an impairment of perception, but if it doesn't impair your social participation and if it doesn't, well, the person doesn't suffer from it, it's not a relevant disease you should take care of unless the person wants to. So there is a stepwise process to be looked at when we talk about patients from the many that have mental illness. It's a small percentage, it's about 1% or so, but still they're mostly in media focus. So if we talk about the few that endanger themselves or others, there has to be a lot of steps taken. Is it really a relevant disorder? Is it not just caused by current problems, like, for example, if you suffer from torture, then you suffer from torture, you're not mentally ill. If you suffer from torture after the torture has stopped, you may have post-traumatic stress disorder, and then, you know, this may be a treatable problem, but everything that can be abolished by just changing the circumstances, you should change the circumstances, not wait for, you know, some medical cure for it. And this, of course, also applies to all the social and climate problems we talk about. And decisively, the person shouldn't understand what the consequences are. Of course, if you can be very depressed and still have good reasons to think that life is not worth living and have a right to die, if you really want so, as long as you understand the situation. If you feel you should kill yourself because you're condemned, because you committed a sin, because some voices tell you that you're a sinner and there's no other reason for that, then you may lack insight. So there's usually in psychiatry a problem between overarching levels of control on the one hand and then rebellion on patients on the other, and it's often a vicious cycle. First consequence of all of this is that in our treatment settings, we need to be more open and we need to allow patients who are, at least all of those, the vast majority who come on their own will voluntarily, to leave the ward again. If you lock up wards for the few who need intense care, instead of putting personnel next to them, instead of providing them with personal contact, then you have an increased level of aggressive incidents, but also of coercion and of people who try to leave. And you can replace that, and here we come into the environmental part. You can replace a lot of institutional care with teams that go home to the patients and their environments and try and take care of them in their community. Now, in their community is not as easy as it used to be, because we thought that, you know, as the moment you abolish institutions, patients in the community are free and they can socially participate. But communities are very different, rich and poor ones, polluted ones, and those with clean air, hot ones without street trees, and those ones with nice parks next to them. And this reflects to a large degree income inequality. And what you see here is an astonishingly strong correlation between mental disorders. This is here on the y-axis, the percentage of persons in the population reporting mental illness, and income inequality, which is the gap between rich and poor in a given country. And you see it's a very, very strong correlation with rich countries like the United States, but that also have high income inequality, having very high numbers of mental illness. Some countries like Italy stick out. They have a rather high income inequality, but not so high levels of mental illness reported. That may have a lot to do with Italy having implemented a community care system. And that's a replication of this finding with respect to depression. It's a meta-analysis. So you see all the studies on the right of this y-axis here do show a significant effect of poverty, inequality in poverty on depression ratings. Those on the left not, and the vast majority of studies shows that, again, the more unequal a society is, the higher the rates of depression in that society. So what contributes to this inequality? One of the key factors is unemployment. You see here, that's data from the US, that 2/3 or even more of persons with mental illness are unemployed. Has a negative impact on mental health, not only on resources. And there are some gender differences that mainly depend upon who takes care in the family and who is responsible for providing the financial means. With respect to the COVID pandemic, we also saw that mental problems associated with these times are much more strongly correlated with unemployment rates. That is here the gray bars that you see. And you see with increasing unemployment in summer of last year, reported mental health problems increased. Interestingly, they did not increase similarly with increasing infection rates. So people did not worry that much about getting infected, but they worried a lot about losing their jobs, which again points to these social and financial inequalities. So one problem of trying to reintegrate as in a community is that you usually have limited access to the job market. And the second problem is that you integrate in very different communities. On the right-hand side here, you see an idealized picture of what we and others thought living in the community should be like. It's a nice old area in some European town, and you see there are no high-rise buildings, there's no factory, there's no street pollution. It's a bit too idealized because our reality, even in Berlin, looks like that. And what you see here is poverty. The darker red or the darker red-brown the colors, the more poverty in this area. The blue circle is the area that our hospital takes care of, and I will show you some data on that in a minute. And the green spaces are usually, as you see here also in green, are the areas close to the parks. So in the left lower corner, that's the southwest of Berlin, you have a huge park. In the right lower corner, which is named Köpenick here, you also have a huge park. And then there are some parks throughout the inner city, and usually close to the parks you have nice areas with people with expensive housing and good income. And the further away you get from that, more into inner city areas without green space, the more poverty you have, and of course the more environmental problems you also have. And this is a enlarged map from the center of Berlin. So whoever has been in Berlin, you see Brandenburg Gate, the entrance to the old city, and you see the TV tower. And what you see here in yellow and red are two working class districts, Moabit and Wedding. Wedding sounds like you marry someone, but it's really the name of the district. And it's a traditional working class neighborhood. Nowadays, it has about 50% of persons with migration background living there. And you also see dark red indicates that more than 40% of the population is jobless and lives on social aid. And interestingly, what we observed is that people living there do have a higher level of mental health complaints. And it's not because of their own poverty that has been taken out statistically from this year, but what instead you see is that it's a poverty in the neighborhood. So even if you are well educated and have a good income and you live among people who are poor and are out of work, your mental health burden is higher. Our American colleague said, well, of course, if you're depressed, you don't move out of an inner city. Everybody who's not depressed would leave inner cities. But it's a very American point of view, because at least in Berlin and in most European cities, it's quite attractive to live in the center of cities. And I think it's really the negative impact from your neighborhood on you, and not that you are not active enough to leave the city. Now, how can we deal with the environmental problems? I wish I could have shown you already correlations, not with poverty, but with pollution or heat waves. We don't have that yet. The data are there, but we are still sorting them out. But I would like to alert you to future potentials to look at all these interactions. And this is due to technologies you all have in your pockets. We all nearly have now a cell phone. And on a cell phone, you can track where the person is. You can ask them how they feel. You can see this is Heidelberg inner city. When you move through the inner city, do you stand in front of a bar or in front of a park or in front of a self-help group or something else? You can see afterwards, when you put people in scanners and look at their brains, how stressed they are, what kind of reactions you find. And you can overlay these individual pathways of persons with all kind of maps, for example, showing, as you see here as some examples, street pollution or number of cigarette machines, vending machines, and so on and so on. So you can see how behavior is influenced. Of course, that's a nightmare for data protection. We have to be very careful. And we have many governments in this world who are not really respecting privacy rights. So it's difficult to do these tasks in an ethically good way, but it's very different to any kind of research we were able to do before. So you can really in the future see how people feel momentarily in a given situation, in a given location, also with respect to all the pollution. With that, I come to an end of this brief overview, and I'm looking forward to your questions.
Thank you very much. Martin, you're still muted. I probably have to consider moving out now, but because I'm actually doing a wedding. But you have to say or add that like many students are moving in here. So I guess probably the social structure will change as well in the last years.
Yeah, thank you very much to all, really, to Clemens, Nightingale, and also Andreas, because you were all three of you are coming from a very different angle, and still there is a common thread. So that would be my first question to you, Clemens. Kind of what are you seeing as a common thread between the three presentations, and what kind of caught you the most from the two others, not your own? Clemens, are you here? I have lost him. Also, Nightingale, are you here? You're here.
Yes, I'm here.
So if Clemens isn't here, you perhaps you can chip in. And what are you seeing as the connecting dots between the three very different angles?
So yeah, it's a good question. And really, like we see, it is looking across all generations and thinking about how our health as humans is connected to the health of the space where we live, which really is the planet. And it, as we look at it, it doesn't come as a planet, it comes as our communities, but especially more and more as we understand what's going on globally, we see that we really need to change, to make so many changes in our lives, not now, but yesterday. But since we don't have yesterday, we just have to act right now. And that's where we involve everybody in this picture. So I really appreciate what Clemens and Andreas talked about. And just thinking, like my organization is in the early stages of thinking about how to partner with all the people that touch on the health and well-being of the children, which in a lot of ways is everybody, but just learning step by step on how to do this such that the child from an early age also knows about heat waves and what that does, even if it doesn't affect this child maybe from one part of the world. It's good to know what's happening to another part of the world, and that it potentially sooner or later something will affect you due to these changes that are happening.
Mm. Andreas, what was speaking most to you from the two other presentations, and how do you see, where do you see the connections?
Well, as this has been stated, I think there are these transgenerational impacts that play a large role. Yeah, if you look at, for example, elderly people in homes in Berlin, we did a study on them. You saw clearly the impact of heat waves and of being in a home. And then on top of all of that is not enough staffing, for example, and overdose with medication. We once did a study in Berlin homes, and we found that about 70% of patients got neuroleptics, which is a medication against psychosis, but they didn't have psychosis. They got it for what is called behavioral problems, where it's not a first-line treatment, and about a third of them got it because they were aggressive. And with aggression, it helps a little bit, but you should have other ways to deal with it, like more personnel talking with them. Sometimes animal-supported therapy helps, like if you have a dog there or something, they can, you know, interact non-humanly. 1/3 got it because they are depressed, and neuroleptics make depression usually worse. And the last third got it because they were apathetic, they had no drive, no motivation, and neuroleptics make that also worse. Now imagine you are over-sedated in a home, and then it's extremely hot. So, you know, these factors come together. And with respect to children, of course, that's an extremely important topic, because in many ways you see that in the city area of Berlin, you have poverty, you have increased drug consumption, you have parks that are full of garbage and not cleaned regularly enough. You have aggression on the streets, and then you have also a lot of racist attacks on people, not really in the city, but as soon as people go out and try and go to the countryside, there's a proper limitation and an unequal access to green space outside, because you may be subject to racist aggression. So the children part is extremely important. And we have Berlin, we can be lucky, we have some parks. Yeah, it's much better than other cities I've seen. But yet again, as if you look at a map of Berlin, the nicest parks are where the richest people live. So there's also unequal access there.
I think it comes out very strongly how social income inequality, how social vulnerability, how joblessness, how access to green parks, kind of how exposure to heat, how all of these things are coinciding or connected. And I think it's very, very important to bear in mind that the most vulnerable will be hit the most from the beginning. So we really, but also how in a way the mental illness is much stronger in societies where you have social inequality because, or income inequality. I think it's very, very important to bear in mind in all of our work, how the social dimension is playing a huge part in all of it.
I was wondering before we get to the questions from the audience, if you already had patients with, I don't know, for example, solastalgia or really like strong worries about environmental change, and if this worsened their, for example, also maybe pre-existing mental conditions.
Let me try and see if I got that correctly, or maybe you can help me again with the question. I'm not totally sure.
If you already at the Charité had patients with strong anxieties about environmental change.
Oh, okay, sorry, yes. Not as much, I have to say. Also not with the COVID pandemic. Yeah, we had patients reflecting when the refugee number increased in the 2015s. We had patients reflecting that sometimes in weird ways, but not very much, not like with a COVID crisis and not with climate change worries. Yeah, I have to say. I think worries are strong, but that people really enter a hospital because of them, a psychiatric hospital, is, in my perception, rare.
So I think we will take some questions and comments from the larger audience. Who is presenting it today? Sophie, please.
Yes, first of all, thank you. There were impressive talks covering broad topics, and I want to pass on a big thank you from the audience because for pointing out the connection between inequality and mental health, as well as the health of both the youngest and the eldest, and also for celebrating diversity. So we probably had even more compliments than questions in the Q&A, and I just wanted to pass this on. And we have some questions that are probably overlapping both with children and adolescent and mental health. So I think this might be interesting for both of you. One question, and we were just on the topic of eco-anxiety, so I'm just going to continue with that, is that you mentioned that on one hand, people can be depressed, but have very good reasons for that. And when we look at eco-anxiety, the question would be, are we pathologizing a very justified feeling in the face of an emergency? Or is it important to name it so that we acknowledge it and the impact it has on people's lives, and especially for the younger generation?
Should I try and answer this, or anyone else? Okay, well, it's a bit like the question of grief. Grief has been a big discussion point in the classifications. Is grief a depression, or is it a normal reaction? And number one, I think mental illness can be a normal reaction. There is nothing in statistics or normalcy, or however you want to define it, that is an argument against mental disorder. And this is an old argument. A very famous psychiatrist, Jasper, said, look at dental problems. Dental problems are frequent in the majority of persons in his time, 1946, but it's still, even though it's normal, it's still a disease. Yeah, it still hurts and destroys the teeth. And with depression, it's kind of the same, I think, but we're losing track of what a depression really is. In my view, a depression is given when you have lost the ability to experience joy or to change your mood. Yeah, and it does not mean that you have a bad mood. We all have bad moods all the time, and we've kind of been overdriven to medicate bad mood states. That's wrong, yeah. And even psychotherapy doesn't always help against well-justified bad mood states. But if you notice that, you know, you're in a bad mood about climate anxiety, and let's say your best friend has just gotten a child that they've always waited for, and you can feel no joy, then it's very difficult for you and for others to live together. And then you may have a reason to get psychotherapy treatment, or in some rare cases also medication. But it's about this, what we call rigidity of feelings. It's not about feeling bad at a certain moment. That's extremely human. I don't want to abolish that.
Maybe just to say a little bit also about children, and this is mainly going to be from conversations and circles that have been around talking about children specifically, but also young adults, and that there's just more and more anxiety, even because there's a lot of talk about climate change and the effects of climate change. And also, as we look forward, what's happening. So I think one of the areas that we will really benefit from focusing on in our discussions is also, so what do we do? Because it's happening. So I think it is very important to name these issues, but also take it a step further and involve everybody, including the children, on what do we do. And that way you don't feel like just a person who's a victim, but you feel that you're taking charge in one way or another. So
Yeah, thank you for this important addition. And I was recently part of a webinar on exactly this, that eco-anxiety is part of, on the one hand, being worried about the state of the planet, but on the other hand, about the lack of actions. So thank you for pointing out again that it's the second part that is also really important. We had one participant in the chat mentioning a theory or something that is proposed that is called nature deficit disorder in children. I don't know, maybe have you heard of it? What is your opinion on it? Maybe you can comment on that.
Yes, so it's by Richard Louv, who's a part of CNN, Children and Nature Network. And I lean towards that end, that there's really nature deficit disorder because of just how much the world has evolved, that we now have more technology that is more interesting, but also busyness in life. And so it's looking at how we can involve children. Technology has really taken and also the fears surrounding having children outside, because if some of us may know, depending on where you lived at the time as a child, remember times when you may have been allowed to go outside on your own and interact with children out in the community and learn from each other tricks that your parents couldn't teach you because they didn't have the child abilities anymore. And it is during those times that you probably learn how to forage, which fruits to eat and which fruits not to eat. And now with the evolution and even with the climate change that forces some people to now stay more indoors than out of doors, there's that loss. And with the nature deficit disorder, as it is being said, or whichever term, other term that you would give, if you don't know what the bush outside is, that it gives you berries that you can eat, then you probably eliminate it and plant a flower that makes you happier to look at. So I think it is there. It's, and it is good. But so Children and Nature Network has a pretty good library that's talking more about these issues and how you can connect children better in the natural spaces.
Thank you for this and for the literature recommendation as well. Maybe a question concerning the first presentation. So you mentioned the different effects of medication in heat wave, and one participant asked specifically about the experience with a baclofen pump, but also I think the big question is, are there lists online of heat effects of medication? Where can we look this up? How can we make sure we treat the patients accordingly? And maybe there are quite a lot of countries in the world where it is actually constantly quite hot. Can we learn from them? Is there any kind of network where we can, share experiences?
I think the principles of clinical pharmacology, of course, apply around the world. So the basic understanding is that if there's more blood flow in the skin, which can be increased in the range of 4 to 8-fold, let's say, to balance. And that also a lot depends on your physical activity. So if you walk, if you have a lot of steps, a lot of physical, let's say, hard work, of course, your heat production will drastically increase. So basically, the only way for us as human beings, let's say, to get rid of this heat, it produces carbon dioxide and heat, is, let's say, by sweating. And in principle, the more blood flow you will have in your skin, the more it will decrease, let's say, for the renal function and also for the hepatic function. And that basically means that for all medications, one should check if they're eliminated via the kidneys or if there's a metabolic function involved. A lot of the medication that we have developed in the last 10 to 20 years have a relatively broad range of, let's say, their therapeutic action. But we also have some medications where actually a reduction in hepatic blood flow or a reduction in renal function have the effects. And so there's no simple answer. So we need to check if we have people with polypharmacy and they're taking, let's say, somewhat unusual medications that we're not totally familiar with, that we should check for each of these substances whether this should be the case. As I've said, one thing that always has to be kept in mind, but we have a number of, let's say, databases where you can check that, is the anticholinergic potential of these medications. And the higher it is, the more relevant it will be. So that's the rule of thumb. And then, as I've said, all the medications that are, let's say, injected subcutaneously have a risk that the delivery of the drug will be much faster. And the most extreme cases that we have seen are with painkillers delivered, let's say, by, for instance, transdermal ways of drug delivery. But there's also, for instance, Parkinson's patients that have transdermal applications. Baclofen is a very special case, so I would have to look it up and discuss it, let's say, with our clinical pharmacologist. So I don't have an answer. There's a couple of very useful databases out there. I will send you, let's say, maybe 1 or 2 reference, but I will also cross-check that with our clinical pharmacologist. That's the most recent. There's some very good German databases like Dosing, but I have to look it up, how good and how relevant internationally what is available. But I'll send you the info tomorrow.
Great, thank you. And we can put it on the website under materials. You can check it out then later. Yeah, I don't know if we have more time for questions or if everyone wants to comment on anything that has been said before.
I maybe have a general question, but you can do 2 or 1 more question. Oh, and until you look it up, I'll just pose my question, because now that we have the 3 of you here, I mean, the connection between climate change and human health is just getting more and more awareness. During the last decades, we weren't like really aware of this connection. How do you experience this change of awareness in your specific field in medicine? Do you have the feeling that your colleagues are quite aware of it, or is it just, are they still skeptic about it, or like, oh, it's not such a big problem? And do you have the feeling that they're like eager to do something about it as well?
I think in the moderate climate zones, I think that most people still consider it like a mockingbird flying around. So what I see that it's not part of the daily business. So for instance, if I look at the people coming to accident and emergency, if they're being sent back home, they normally will not get a recommendation what to do in the next 3 days where the temperature is, let's say, 35 or something. Of course, if I talk to colleagues in Sydney or if I talk to colleagues in other climate zones, for them it's somewhat more common, but it's about the level. I think that, for instance, the topic on how to have, let's say, a hospital building that has a different approach to energy consumption. I think a big area is also, let's say, the mobility and transportation. So if we see how many physicians and nursing and other healthcare members still use their car instead of using the bicycle or other forms of public transportation. It's still annoying. So I think that step by step, the situation is getting better. There's more awareness, as I've said, but I think we're still far beyond a real tiller-totter situation where people take it as a very serious topic that also, let's say, is directly associated with that.
Anybody else? Yeah.
Maybe I can add, I think, at least in our field, it was really very much in Germany depending on the hot summers of last years. Yeah, before people noticed it intellectually and didn't really care. And my feeling is that only was really experiencing, be that accidental or not, but experiencing somehow how volatile the weather has become, it has had some impact. And our society, for example, Psychiatry Society, is now more active. I hope it remains this way, but it's a recent phenomenon.
I guess just to touch very briefly on a snippet that was mentioned by Clemens is coming in as a registered nurse is connections within that region or that group is there's still very little information that's out there. Generally, the nurses are mostly focused on practicing what needs to be done, get the patient taken care of, and then you move on to the next thing. And so I think this is an area that's really, really ripe for knowing about these issues related to climate change, because this is a person who has a very close contact with the patient and is going to probably give the final, like if it's within the hospital setting, you're going to be giving the final recommendations that have been given by the provider or by the nurse before the patient leaves. And so that's what they will remember, as well as within the clinic. But also just touching very briefly that even when it comes to nutrition, generally these people, their nutrition is not good at all because they need to eat quickly, and those quick meals sometimes are not the best. And so you see that even obesity, you have more obese healthcare practitioners than you would want to see based on that. That's the advice that they will then turn around and give. I just wanted to focus on that a little bit.
Maybe just to add, for me, this is a classical example of where it's not high tech, it's high touch. So the actions that you have to deliver in these times are really, let's say, not the technological measures. It's a lot about, let's say, sharing and neighborhood and family. And I think we need to just remember and remind us that if we want to, let's say, deal with this situation, this is a societal action. It's not at the high end. Nonetheless, of course, we need the specialists to be aware. But I think to take care, it will take the neighborhoods and the families and so forth, a lot of volunteering. That's at least what I've learned over the last couple of years.
Thank you. That's a really nice term, actually, high touch and not high tech. We should make that a new trending hashtag. Sophie, do you have another question?
Yes, and I think it connects well with this societal perspective. So, of course, we need a lot of volunteers, but we also need policies. And we have seen you all outlined very well that we know the impacts. And in some places like Berlin, we even have the detailed maps on the impacts. And my question would be, do you feel like this knowledge is being used for policy and planning? And what would if you had one wish to policymakers, what would that be?
Well, my comment would be, of course, each country has to check that on their own. But if you have a federal election coming up and the political situation is unclear, this is the perfect timing to really, let's say, go for town hall meetings or, let's say, web formats and so forth. So let's say 6 months from now, the story is done. So I think we need to focus on these opportunities that open up. And as our colleague Andreas has said, sometimes you really have to wait until you release the press and discuss with other people. Otherwise, it's just a waste of time. And I think each country, each state really has to think about what is the optimum timing to get this discussion going and rolling. And it's a lot about, let's say, strategy and sometimes tactics, how we should do it.
Thank you very much. So as a final question, I want to come back to the red thread of this discussion, which was about the social question. And one of the discussions now in the election is that we cannot have ambitious climate action because it is not social. What we've seen, it's just the other way around. So my question to you is, what is your idea of how we can frame how, in order to be fully aware of the social question, we have to do very ambitious climate action? So any ideas you can bring to us in our next 3 months, where many of us will be out on the streets and in many situations kind of trying to influence the election, to bring our topic to the key of the discussions and the agenda, and I hope even the heat is helping us. So what is your idea of framing it as a social topic?
Well, if I may, very simply, I think it hits those who are poor the hardest. And of course, you have to see with taxes, with raising prices on pollution and so on, how that is embedded in a social framework. But doing nothing is really, people who have more resources have more chances to at least make their life more pleasant in the next 1 or 2 decades. Yeah, and it will hit those who live in the cities who have no money, or also we don't want that everybody has climatization in their rooms. It costs a lot of energy and brings in chilled air and other health problems. So it will hit those the hardest who have the least resources if nothing is done.
Clemens, any idea you have how to frame this?
Yeah, I think a discussion that we are currently having with several people is, I think it's how can we empower people to some extent so that every one of us can make somewhat of a difference. I think if we just leave it, let's say, to a meta discussion of politics, it's okay, and we should definitely go for it. But I think we should think about what everyone can do. And one of the things that I think could be relevant is, for instance, the discussion on decarbonizing food. So I think a big issue is if we ask people to think about, let's say, either being a vegetarian or eating in a different way, they can definitely contribute to the society of less production of carbon dioxide. Another topic that I think is relevant is that we should consider the change of mobility patterns, let's say from technically and fully technically supported solutions towards hybrid solutions, or let's say physical activity. I mean, from a health perspective, it's super easy and a no-brainer to say, if you leave your car and you take like either a pedelec or a bicycle, you make a big contribution. So I think that for the social agenda, I was very scared to see that at least some of the parties are now, as you have said, kind of like asking or telling us that there are not enough resources and we're asking too much from some people to make a significant contribution. I think that's a big danger. So I think we should think about and reverse the situation so that we can make good use cases, how everyone can contribute, and that we need everyone also as part of this changing story. And these are just decarbonizing of food and mobility are 2 examples. And I'm sure that other people will have many other examples.
Thank you very much. Nightingale, anything you want to add?
Well, just wanting to say, also thinking about subsidizing the right foods would be very helpful. So looking at it from a policy standpoint, because right now the foods that are subsidized are probably not necessarily in the countries that do subsidize. Like for instance, the US has that. where you find we're feeding more animals than we're actually thinking about feeding people, and what are we feeding them. And again, I will also mention that having children at the table is so important, because and once we have the child involved in a lot of these activities, the child will bring with them their parent or their guardian and whoever else is surrounding them. So involving, just like Clemens said, involve everybody at all the different stages, so that you feel useful and you're actually useful in making the change.
That's a great thing, because we have seen how the kids have been taking the lead. And I feel, you know, whenever kids are involved, it is high touch. And when you were saying before in your presentation, you know, take the kids that you either are close to you in your house or in your mind with you into this presentation. Of course, my grandchildren were there. So if you're telling the story with the children, it includes the children into the work, you know, and there's a lead, this can be a game changer. So I hand over to Sylvia to close the session. But from my side, thank you very much for your great input, and very kind of, I take a lot with me. Thank you very much.
Yeah, thank you from my side as well for this really nice input. We're happy to welcome you to our next session on how we can create, like we will touch on points that we've talked about today as well, how we can reimagine life and how we go beyond exploitation and kind of reimagine the connection between nature and humans. So have a nice evening, and see you next time. Bye.